and gentlemen, it's really nice to meet you here in Vilno, and this is a special place for me because my grandfather finished his secondary school exactly here in Vilno. So really welcome and thank you for invitation of this conference. I'm a clinician, I'm a medical doctor. I work in an infectious diseases department at the Vroclavo Medical University, and I would like to discuss with you about some aspects, some clinical aspects of the Lyme diseases, because we know we have quite big knowledge about this disease, but we have still some troubles with diagnosis and good approach and good treatment of the patients with the Lyme disease. So now I will tell you about some myths that are very popular here, that are very popular in Poland. The myth is that the Lyme-borreliosis is like malaria of the north. There was the article in the newspaper published in Poland, and the title of this article was the Lyme-borreliosis, the malaria of the north. Why we have a problem with these myths? Because many people, many clinicians in Poland believes that this disease is the chronic disease, and this is untreatable. This is impossible to destroy, to stop infection. And many patients believe that they will need antibiotic therapy to the end of their life, and they ask the doctors to continue with drugs for many months or even many years. So, because of that, we have a trouble with Lyme-borreliosis. But what are the facts? The facts are that the borreliosis is the spirochetal diseases. It's caused by spirochetes that can spread from the tick bite place with the blood to the other organs and can cause the acute organ manifestation. And when we will not stop the infection in this moment, the disease will progress to the chronic form, and the organ manifestations in some patients will now resolved. Sorry. What are the typical manifestations of the Lyme disease? The most typical manifestations is erythema migrans. The erythema migrans can be observed in about 75% of the people, but please note that 25% of people will never observe the erythema migrans. So even when the patients will not report you erythema migrans, so that is not proof that this patient is not infected with Borrelia. The other typical manifestations, clinical manifestations, is the neuroborreliosis and also the Lyme arthritis. The prevalence of the Lyme arthritis differs in the United States and in the Europe. The other rare complications, the rare manifestations of the diseases, is Lymphoadenosis cutis benigna, Acrodermatitis, chronica, atrophicans, carditis, and ophthalmoborreliosis. These presentations of disease are very, very rare. And the prevalence of individual symptoms varies depending on studies group, regions of the world, and diagnostic criteria, and the difference may be explained by the organotropism of individual Borrelia genospaces. We know that in the North America the genospaces of the Borrelia are different than in the Europe. So because of that, the prevalence of the main symptoms can differ between the regions. Like in the other spirochetal infections, in the Lyme diseases we can find few stages of diseases. In Lymphoadenosis we can distinguish three stages. Stage 1 is the early stage of diseases. In this stage the characteristic manifestation is migratory erythema, erythema migrans, accompanying by non-specific like flu syndromes. In stage 2, weeks or even months after the tick bite, some neurological symptoms and symptoms of arthritis and symptoms from other internal organs can be observed. In the most advanced stage 3 of diseases, the arthritis can be observed, and also chronic changes of the skin, and also the chronic neuroborreliosis. In stage 1 infection, we should remember that this is the local infection. The characteristic for the local infection is, as I told you, the erythema migrans, rare manifestations, lymphoadenosis, cutis, benigna, and these manifestations sometimes can be accompanied by non-specific symptoms like muscle and joint pain and fever. That means that these complications, these signs, we usually told that this is the flu-like syndrome. Erythema migrans occur after several days or weeks after the tick bite, regardless of the patient age. And the erythema is clear-edged. In the center there may be a lump with clearly visible border. And about 20% of the patients complains about the parainfluenza syndrome, but please remember that only 40% of the patients recalls the tick bite. It is connected with the fact that very often the people are bite by the larvae, by the larvae of the ticks. That is very small and very often can be invisible for the patients. Numerous erythemas stem for the blood-borne dissemination, and they are more common in the United States of America, in the North America, than in the Europe. And some percent of the patients can report sensation disorders in the place of erythema that is connected with local neuritis. Usually, untreated erythema will resolve in 4 to 5 weeks, usually. When we see the patients with erythema, we should remember about the differential diagnosis. The very similar changes on the skin we can observe with reaction. It can be, sorry. Oh. Okay. Very similar changes on the skin can be evoked because of insect bite indeed. Also erysipelas can, the picture of erysipelas can be very similar. Drug eruption, annual erythema, and also skin mycosis. On this picture and on the next slide you will see a typical picture, typical view of erythema migrans in a patient. And here, look, border of this change, and when you see the patients with erythema, and when you are not sure if the change that you can see now is the erythema migrans, the good method to check it is to measure the diameter of this change and to put a sign on the skin of this patient. For example, you have a child with a small, for example, 5 cm diameter change on the skin. You are not sure if it is erythema migrans, so check the diameter, sign on the skin, and please ask the patients to come back to you for few days, for example for 3 or 5 days. If this change will grow, so then the chance that this is the erythema migrans is quite big. And when you have the patients with diagnosed erythema migrans, so don't do the serological test in this situation, because erythema migrans is the acute phase of infection, and in the acute phase the serological tests can be false negative, because our immune system will need few days or few weeks or even few weeks to produce antibody against Borrelia that we are looking for, yes, in a serological test. So when we recognize erythema migrans, we should start with a treatment. And the second changes with a multiple erythema migrans, and here also the multiple erythema migrans, very rare in picture in my practice and also in Europe. The other acute phase, the other acute form of dermatoborreliosis is lymphoadenosis cutis benigna. So lymphocytoma may occur simultaneously with erythema migrans. That means that it can occur in this same time or just after the erythema migrans at site distant from the tick bite. So it usually will grow not in the place when the tick bites the patients, but in the other places. Typical is bright red soft edema or lump with forms as a result of the proliferation of lymphoreticular cells of the skin and subcutaneous tissue, and these changes typically is located on places of the skin that are well vascularized, such as earlobe or mamilla. The size of this change is usually very small, half to 5 centimeter, not larger than 5 centimeter. And also here in differential diagnosis we have to remember about the other causes of this change, of this eruption. So it can be evoked by reaction to insect bites, it can be histiocytoma, sarcoidosis, even cutaneous B-cell lymphoma or lupus erythematosus. And on the next slide you will see the typical changes, typical lymphoadenosis cutis benigna, earlobe, the color is typical and the place is typical, and here under the eye, and here also. In stage 2 we will observe multiple organ, we can observe multiple organ disturbances after spreading of the bacterial to other organs. So we can find the signs of neuroborreliosis in the patients. We can find arthritis, and also we can find the other organ changes, disturbances in these patients, like carditis, hepatitis, and very rare complications, ocular borreliosis. The second stage of diseases usually start 2 to 10 weeks after the infection, after tick bite, and usual symptoms, for example, usual symptoms of arthritis occur 4 weeks after the erythema, after the occurrence of erythema migrans. So, as you know, the erythema migrans usually resolved after 4 weeks. So 4 weeks the patients will have erythema migrans, and after next 4 weeks we can observe the first signs of arthritis. But please remember that in some patients there are no skin changes, and the stage 2 signs, the signs of the stage 2 of borreliosis, can be the first sign of diseases, and especially in these patients with suspicion of neuroborreliosis, with suspicion of arthritis, especially in these patients, we should perform we should perform serological tests, not only ELISA tests, but also Western blot testing. It's very important to diagnose the disease in stage 2, because in stage 2 the symptoms can resolve. In stage 3 not all symptoms will resolve. So in stage 3 we will have the chronic disease. Lyme arthritis clinically, it progresses as a mono or oligoarthritis, usually monoarthritis, and that involves large joints, most often knees, ankles, elbows, but sometimes also the minor joints of the hands. Clinically is the exudate in the joint with restricted mobility of the joint, but there is no high arthralgia of changed joint. In about 10% of the cases can occur the Baker's cyst. The course of disease is chronically recurrent, and without treatment we can expect that after 6 months, so it's about after half a year, all symptoms will resolve, but the 1/3 of the patients will in the 1/3 of the patients the changes will be present in the next month. In about 10% of acute arthritis turns into a chronic form, and the predictor of the chronicization of the process is the long-lasting and intense deterioration with a shorter periods of remission. Chronic arthritis is not recurrent and is continuous and progressive with mostly unilateral or bilateral symptoms or of knee joints. In differential diagnosis, we should remember about the other cases of arthritis. Arthritis caused by precipitation of crystals, reactive arthritis, arthritis related with chronic inflammatory diseases and psoriasis, symmetrical arthritis of small joints of the hands. This is the not typical picture of borreliosis. When you have patients with these signs, please diagnose at first. Think at first about the rheumatic arthritis or psoriasis than about borreliosis. But of course, also in these cases, the serological tests against borreliosis should be considered, and it will be good to make these tests. Neuroborreliosis, this is the second presentation of acute phases of disease, occurs circa in about 10 to 12% of the patients with the Lyme infections. Typically, it occurs in the second or third stage of disease. Sometimes, in the first stage of disease, patient can report the headache, but in this stage, the headache is the one part of the symptoms of the flu-like symptoms. So this is the not typical neuroborreliosis. If we would like to establish the diagnosis of neuroborreliosis, the examination of cerebrospinal fluid is absolutely needed. We can recognize the neuroborreliosis only then when we find typical inflammatory changes in cerebrospinal fluid, and when we find it, we can establish the diagnosis of the stage 2 borreliosis. Because the inflammation process caused by Borrelia burgdorferi in the central nervous system can destroy the whole neurons. So the picture, the clinical picture of this disease is varied. We can observe mono or polyneuritis in the patients. Very often in my practice, I have patients with lymphotic meningitis, with meningoradiculitis. Rare complications is paraplegic myelitis, myeloradiculitis. I also observe the patients with encephalitis, and as other spirochetal diseases, also Borrelia can cause the inflammation of cerebral vasculitis with cerebral infarction. Some patients can develop the progressive encephalomyelitis, that is life-threatening complication of Borrelia. It can be life-threatening complication of Borrelia. So most patients with neuroborreliosis report first symptoms between June and October, and the second leading symptom is radicular pain, reported by even 70% of the patients. We very often have the picture with a headache and, for example, with symptoms of radicular pain. We also very often observe the patients with the nerve palsy. Also other syndromes like myalgia and fever can be observed in these patients. A small group of patients will present other symptoms of neuroborreliosis, like progressing walk disorders, psychoorganic syndrome, and stroke connected to the changes with the brain vessels. Quite rare complication is Lyme carditis. In my practice, I've also met the patients with this complication, and the prevalence of carditis is about 3% in Europe. It's higher a little bit in the United States, and the most common clinical picture includes impaired conduction of the stimuli. So we will observe the atrioventricular blocks of various degrees, atrial fibrillation, and extrasystoles. Usual cardiac symptoms do not last long. They resolve after 3 days to 6 weeks. So when you have the young person that was exposed to the tick bite and with, for example, the impaired conduction of stimuli, and when you exclude the other causes of, for example, atrioventricular blocks or atrial fibrillation, so in this case we also should remember about Borrelia, and we should perform serological tests against Borrelia. First ELISA and then Western blot test. After the acute stage, the chronic stage of disease, the disease will progress to the chronic stage. It is the last stage of diseases, stage 3. And as in the earlier stage, we will observe the change in the central nervous system. We will observe the neuritis or We will report the neuritis or polyneuritis, progressing encephalomyelitis, and damage of the cerebral vessels. We will observe also the skin changes, chronic skin changes in borreliosis. It's Acrodermatitis, chronica, atrophicans, and Lymphoadenosis cutis benigna. Also, the borreliosis can be cause of limited sclerodermia. The chronic arthritis is also present in patients with the stage 3 of diseases. As definition tell us, the chronic means that all symptoms we have to observe longer than 6 months.
So when the patients will come to you and will report that, oh, I have a pain of my knee 3 months, so it's not chronic infection. We have to wait 6 months to recognize the chronic infection. And in this stage of diseases, the full recovery should not be expected. And as I told you, so the antibioticotherapy in this stage of diseases is not so the efficacy of therapy in this stage of diseases is not so high like in the earlier stage of diseases. So it's too late to observe the full resolving of all the symptoms. The interval between the first symptoms, for example, erythema migrans, and symptoms of the stage 3 can be between 4 to even 12 months. In some cases, Acrodermatitis chronica, atrophicans, can develop even after few years of Borrelia infection. And please remember that in the most cases of disease, the disease is primary, chronic, and progressive. Acrodermatitis chronica atrophicans at the beginning is usually lesions similar to the erythema or a bright red edema located asymmetrically on extensor parts of the forearms and or limbs. Clinically, we can see an atrophy of the skin. The skin is paper-like, very thin, pergamene-like, and the vessels under the skin becomes more visible for us. These changes, in the basis of these changes, is the atrophic lesions of elastic elements of the conjunctive tissues. And in the differential diagnosis, we should also remember about the chronic vein insufficiency. The changes on the legs can be very similar in the chronic vein insufficiency, like in the Acrodermatitis chronica atrophicans. But please note that the changes that we can find in the patients we will find usually in the forearms, not so often on the lower legs. And changes typical for chronic vein insufficiency typical are located on the lower legs. And here you can see the typical changes. This is the earlier stage of Acrodermatitis chronica atrophicans with edematous changes, red skin color, and here also changes very similar to the chronic vein insufficiency. And here look very thin purple-like skin with very good visible veins under the skin. Lyme encephalopathy is the third most common complication of the chronic diseases. The disease picture is characterized by memory and perception disorders and with fatigue. We can find the changes in some psychological tests. We can find some changes in cognitive tests. And also, when we will perform, for example, the EEG and modern nuclear examination, resonance of the head, so then we can also find the picture of chronic encephalopathy, of chronic neuritis. Very similar picture of the changes of the chronic neuropathy we can observe also in HIV infected patients, yes, and also in HCV infected patients. And also in these patients we will observe, for example, cognitive disorders and also the chronic fatigue. But when we would like to, once again, when we would like to to check if these changes are caused by Borrelia. So we have to perform the lumbar puncture and examine the cerebrospinal fluid to find there the typical changes, and also we have to examine this fluid. We have to test cerebrospinal fluid. We have to perform the serological test against Borrelia in cerebrospinal fluid, and we do it in our practice. Other internal manifestations are really very rare. We can observe isolated involvement of kidneys, liver, spleen, and lungs. In circa 40% of the patient, the elevated activation of transaminase and GGTP can be observed, and proteinuria was reported and hematuria was reported in about 6% of the patient with the chronic Borrelia. The problem is the post-Lyme syndrome. The post-Lyme syndrome, the definition is that the notion of post-Lyme syndrome includes complaints that began in relation with Lyme diseases and persisted for months or years despite an appropriate antibiotic treatment. The synonym is the post-treatment Lyme disease and chronic Lyme disease. And this is the big clinical problem, because the patients have symptoms, they believe that they have active infection of Borrelia, and they very often ask the doctor about the next month of antibiotic therapy. For example, in my practice, I've met the patients that took antibiotics per 1 year or per 2 years. Doxycycline, amoxicillin. Sometimes the patient used metronidazole. Sometimes the patients used, and please note, use the anti-malaria drugs. It is crazy, but there are some pages for the patients in the internet, and the patients believe in the internet informations, not on the informations that they heard for me. So the prevalence of post-Lyme syndrome was evaluated to be from 30% even to 53% in other studies. So it's quite common complication of the borreliosis. And the point is to discuss this problem with these patients, because I'm not sure if you have national guidelines of borreliosis therapy here in Litva. We have this in Poland, and these same standards of therapy are in the North America, in the Germany, in the Austria, and in the all Europe. So I think that you have these same standards, and we know that we can treat the patients with antibiotics only 2 times. When the symptoms didn't disappear, when the symptoms didn't resolve after the second antibiotic therapy, we shouldn't try to treat patient once again, because we haven't no clinical evidence that the patients will have some benefits from this therapy. And as in the other chronic multi-symptom disorder, in the post-Lyme syndrome, the patient will report the cognitive disorders, fatigue, muscle and joint pain, headache, and other problems like hearing loss, fainting, mood disorders, paresthesia, sleep disorders, and other. And the etiology may be manifold. Some doctors said that maybe the post-Lyme syndrome is connected with the persistent recurrent infection, but we have not good evidence, clinical evidence, that it is possible. There is no evidence that Borrelia can persist in humans' body for many years. maybe the post-Lyme syndrome can be connected with the reinfection. As you know, when somebody was infected in the past by Borrelia, we can find the antibodies against the Borrelia, but these antibodies will not protect against the next infection. So this same situation like with syphilis, yes, when somebody have had a syphilis in the past, so this man or woman can be infected once again in the future. Yeah? So the reinfection is possible. Maybe the post-Lyme syndrome is caused by secretion of toxins during the reactivation of infection. And in my opinion, the best reason for the post-Lyme syndrome is the post-infection immunological and inflammatory process. Maybe we observe the autoimmunological, autoaggressive process, or maybe we observe the persistent post-inflammatory damages, but without active bacterial infections. So when we have the patients with the suspicion of post-Lyme syndromes, we have to check once again other possible diagnoses. For example, I've met in my practice the patients, it was 32 young boy that reported the pain of the muscle and the joints since 1 year. He was diagnosed by 4 doctors, and the doctors performed the ultrasound examination of thyroid gland, and they found there the small change, 1 centimeter diameter, and X-ray examination of the knees was also performed, and I showed this picture of the result of this examination, and there was there were the focuses of osteolysis in these bones, and the radiologist said that these changes are typical for borreliosis. This young guy was also treated by the surgeonist. And surgeonist performed the other test, alkaline phosphatase, that was very high, and also the other phosphatase, and also the activation of these enzymes was very high. So also the patient was treated by a rheumatologist, and rheumatologists exclude the other causes of arthritis, and the diagnosis of borreliosis was established. This diagnosis was established only on a basis of 1 ELISA test, and in this test the EGG was positive. And the Western blot test will not performed. Per 1 year, this man was treated by antibiotics, and he comes to me for the consultation. And you know, I found this change in thyroid glands, the high level of alkaline phosphatase, typical changes in the bones, so it was the parathyroid gland adenoma that produced parathormone in high doses, and because of that this young guy have these symptoms. And 4 doctors have seen these patients, and these patients was treated 1 year, yes, by antibiotics, because the doctors recognized the post-Lyme syndrome. So please be very, very difficult when you try to establish the diagnosis of post-Lyme syndrome. And now short about the treatment. As I told you, there are national guidelines for a treatment of Borrelia, and in the first stage we should use doxycycline 200 milligrams per day for 2 or 3 weeks. Not 4 weeks, not 6 weeks, not 8 weeks. In my practice, I very often observe that the general practitioner prescribe the doxycycline per 2 months, 3 months. I don't know why. Please don't ask me. The other drug that we can use is amoxicillin and also cefuroxime. When we have a child as a patient or pregnant woman, so then the amoxicillin can be used. If patients are allergic to any of the medicines, we can use erythromycin also. Treatment of neuroborreliosis. Due to weak penetration of antibiotic to the central nervous system, the drug should be administered intravenously, and in this stage of diseases, we should use cephalosporin of the second generation, and this drug should be administered intravenously. So that means, in Polish conditions, that the patients with suspicion of neuroborreliosis should be hospitalized to perform a lumbar puncture, and when we have changes in cerebrospinal fluid, so then we can start with these drugs intravenously. In case of the Lyme arthritis, we the doxycycline is recommended, and we should avoid steroids. Non-steroid anti-inflammatory drug can be used because they are safe for a patient. And treatment of Acrodermatitis atrophicans, it can be beneficial for the patients, but only in the first stages of these diseases. When we will have a patients with advanced diseases, so please don't expect the resolving of the skin changes. The skin changes will be present, and in this stage, all that we can do for the patients, we can recommend, for example, some creams and ointments to preserve the skin, of the thinner skin of the patients. And the problem is that with the cases resistant to treatment, and as I told you, we can try to treat Borrelia infection only twice. For example, when we have the patients with arthritis, and we recognize the stage 2 of borreliosis with arthritis, so then we start with antibiotics, with doxycycline. And when the symptoms will not resolve, and when we will find the serological markers of acute Borrelia infection, of active Borrelia infection in the serum, so then we can try to start with the second-line therapy with other antibiotics, and the drug of choice are cephalosporins, and the patients should take the cephalosporins per 3 days. We'll also can use cefuroxime in these doses, for example, per 2 days, and after these 2 days, it should be a break about 5 days, and we can do this therapy 6 to 8 times. And when we have the patients with post-Borrelia syndrome, there is no clinical evidence that the continuing antibiotic therapy will bring some benefits to the patients. So please think once again about other diagnoses. Don't use antibiotics chronically. Thank you for your attention.